So I'm a foot and ankle surgeon working in York, for those who don't know me. Diabetic foot, I've been doing it for a lot of years, and I actually really like it. I find it one of the more rewarding bits of my job. What is its natural history, I was asked? Well, obviously amputation is what will eventually happen if you do nothing. And why is, I mean, how big a risk is this? Is that just like one of those little things or a big thing? You get about 100 major amputations per week happening in the UK, of which about 1 in 10 ulcers that you'll see in your lifetime will turn into a major amputation. 70% mortality within 5 years, clearly not related directly to the amputation, but gives you an idea of how these patients are being looked after in general. And of course, their quality of life matters a lot if they're losing their legs. I'll just put this picture up here. Obviously, this patient's very bored and got some children's Lego to make their own leg. Obviously not at work doing a job. And I do think orthopedics can genuinely step in and make a massive difference to this. And this is why I got really interested in it. The problem we've got with vascular surgeons, which would manage the majority of these things, is they only know one operation, and that's to cut stuff off. And they don't really know how to reconstruct stuff or change the shape of stuff. So that's, really important we get involved. So I talk a little bit about what is the natural history and why does it happen. It's an aging process. It's a nice, easy thing to remember. This is aminoglycosylated end products. And essentially, to you and me, orthopedic speak, protein, sugar sticks to it, then it sticks to another one. And so the proteins end up binding together, and that'll affect, the simplest one to think of is like a tendon or something where the strands stick together, but obviously that'll affect enzymes and all sorts. So we get protein dysfunction, and it's often permanent. The reason that's relevant is that if you have a protein that's replaced in your body regularly, you'll think about your HbA1c for this one, so your hemoglobin's replaced every 100 days, then you can actually just monitor that. But there's lots of proteins in your body that will never be replaced again, like in your nerves, like in your livers, like in your eyes and things like that. So it's quite important that we try not to get them to that point in the first place, as it stops them working. Now, we talk about nerves and vascular. That's one you're probably most commonly familiar with, is that the nerves stop working and the blood vessels will clot off. But we've got to think about the tendons and muscles. There is lots of protein in those as well. They will shorten, is the most common thing that happens with those, or they become brittle and rupture. Your neutrophils, they've got a lifespan of about 5 or 6 days, but they also will become dysfunctional with high sugars in your body. And they're really important both for healing, but also for controlling infections. And then we've obviously got the eyes and the kidneys. If you're blind, you're more likely to fall over and cause other orthopedic injuries. And if your kidneys don't work, then obviously anesthetics and things become quite high risk. And so, nerve damage. The obvious one is the sensory. If you've lost your ability to notice pain, you can stand on a nail and they don't even notice it. That is ridiculously common, more than you'd think, particularly when they're wearing rubbish shoes like these. The motor side of things, we talk about the motor causing a little bit of maybe a bit of spasticity or maybe changes the function of the foot. It probably affects balance more than anything else. We do the tendon sort of tightening is what you're probably getting with the clawing of the toes and the tight equinus thing rather than a motor nerve thing, but nonetheless it does affect it. This is the one everyone kind of half forgets, is the autonomic nerves. They are involved in vasoregulation in your foot, but they're also involved in sweating. Your motor nerves do the sweating, of course, but your autonomic nerves are also very involved in the skin health in general. So I would sit there and say this is probably the 3 main nerves that you have to think about, not just the sensory. And then the last one is their proprioception goes. They are, that becomes really relevant when you're operating on them, because if you're going to straighten things out for them and they're using their feet in a way to try and stay clawed to the floor, and maybe you release a tendon or you do something else, then they actually become much less balanced and they fall over a lot more. And they will complain to you about the fact their balance is gone. So you have to be careful about overdoing things, particularly with tendon transfers. So this is just a sort of, a slide which kind of helps you cover everything. So the high glucose affects all of these things, mostly the tendons. But the way to think about it is they get increased inflammation and poor ability to heal. So that's one factor that goes into diabetic foot. The other one then is obviously the arterial disease and all the problems that go with blood vessels needed to bring in those healing cells in the first place, and then all of the deformity stuff, which is where we come in. But I think an orthopod needs to know all of this because at some point you're probably going to have to make a vascular diagnosis and obviously a call on whether their diabetes is good enough. So what causes it? I think the best way to think about this is we do know about the obvious ischemic ones and the obvious neuropathic ones, but there are the ones in between that have got a bit of both. All right, so really important that we kind of think about what those are. And when it comes to sensory, we've got the obvious weight-bearing areas, but don't forget about the non-weight-bearing areas, such as a rub on an ankle, lateral malleolus and Achilles that gets affected, that sort of thing. i.e. pressure areas don't necessarily need to be on the sole of the foot. Trauma, they do have kind of one of the theories, isn't it? Often we talk about diabetic feet is that they are more likely to break a bone. And I think that's probably true from all of those factors, being blind, being poor with the balance, being poor with everything else as much as anything else. We do see a lot of blistering, so that's more of a shearing type problem. So we're not talking necessarily about a pressure overload, but about how the skin on the bottom of their foot when they walk is rotating as they walk, and they just produce blisters. That's why you need a really good biomechanical podiatrist. That's why you need a really good knowledge yourself about what might be causing that, because you can add things to their patient's shoes, insoles, etc., to really help and make a big difference there. The cracks and breaks in skin, as an orthopod, you're like, who cares? But I think in reality we do. And it's not just about who cares in terms of what's going to affect me, but it's like, what could I actually offer a patient to do it? And it's not just moisturisers. There's an awful lot of stuff out there. Again, knowing your podiatrist, particularly the diabetes ones, will help you a lot with that. As I mentioned, the blisters already, and the vascular insufficiency at that end. So what about the bones? There's something very weird about bones, very specifically with this high sugar thing, is that we mentioned about this attaching to proteins, but particularly in bones, we also have sugars converted into alcohol, which can be toxic in itself. It's a kind of a weird little thing where we don't really know why that's going to make a big difference, but we do know that, for example, people who are alcoholics and diabetic get a much, much higher problem with this than the other ones. So that might be one of the pathways. It does inhibit some of the osteocalcin and alk-phos. As you know, they're part of the bone normal turnover from osteoblasts. And it doesn't just affect their internal enzymes, it actually stops them differentiating. And then, obviously, overall, that affects bone turnover and remodeling. Very important bits that we see. And I put the caramelization in because it's essentially the same thing that happens when you're putting sugars into foodstuffs and then cooking it, is that these sugars kind of attach and do these things. The last thing I thought about with bones particularly is I'm yet to find a diabetic with a normal vitamin D when I used to test for it. Multiple fold for that one, who knows? Might be an absorption thing, who knows about that one, but I suspect it's because a lot of them don't go outside, particularly when they get into the orthopedic end and they don't get their sunshine. Maybe their diets aren't so good either. Now, I've just put this in as a kind of big thing there, because it does bug me if people say, oh, the diabetic, I'm going to treat them differently. It's not the same thing as saying diabetes is complicated or uncomplicated. So if a diabetic has got a normal sensation, normal blood vessels, the HbA1c is less than 60, and everything looks good, just treat them like a normal patient. Don't be doubling the healing times and don't be putting extra metal work in. It's pointless. They can be treated like normal people. So it's very important I send that message home. I think if you've got the complicated diabetes, either neuropathic or the vasculopathic or whatever else, then obviously you do change your management plans with them. So, when we talk about Charcot, there's a lot of debate about what causes it. Charcot himself, I don't know if you know this guy, but he's French. Not the first person to describe it, actually. He had it with patients with syphilis and the sort of neuropathies that went with that one. Not him personally, but his patient group. And he called it osteopathy originally. Arthropathy, because they thought it was all about the joints. We now know it's actually the bone. It's the subchondral bone that collapses rather than the joint itself. So it's had a little bit of a change there. Just on the by, the original guy that described it was a guy called Mitchell from America, but we didn't like the Americans at the time, so we didn't give it to him. We gave it to the French instead, so a bit of politics there. So there's a sensory theory. If you are numb, you break stuff, you don't notice, it flops around in the breeze and you make it worse. That's the kind of sensory theory. And there's some logic to that, and there are some animal tests that say that. The second theory is the autonomic vascular theory, which is when you have a reduced blood supply to a bone, AVN, the bone becomes sclerotic and hard. We've all seen that in our experiences over the years. If you actually add blood to a bone, i.e. take the regulation off it, it becomes osteopenic. So you'll see that in CRPS, post-healing things, that sort of stuff. And that's one of the things that we think happens here is that you get more blood into your feet rather than less, and it causes an osteopenia, weakness, and then collapse. So that's the vascular theory. You're going to meet people who believe both. It's probably a bit of both, I don't know. But nonetheless. But that periarticular weakness causes fractures. We see ligament failures, i.e. they get avulsion fractures off that. And then, of course, we get the instability. Ultimately, the tendons and forces displace it. You'll see Charcot anywhere. I've even seen it in a hand with someone who got a transection of a median nerve. It's very, very rare in the hand, though. And probably because of this bit, is it mostly happens between the cuneiform and the navicular. Anybody know why? It's a really weird bit of your body, this. It doesn't happen really anywhere else. Your antagonists and agonists are on different bones. So your dorsiflexor's on this bone, your plantar flexor's on this bone. So it collapses this way, because your natural tendons are going to be pulling on it all day long. And it's very rare. You normally have your agonist and antagonist on the same bone, yeah? So that's why that's quite interesting on there. And then if you want to have an idea what the problem is, I often just draw a line from my sesamoid to my heel. Anything below that's not supposed to be there. It's not the right shape to walk on, and the chances are they're going to get pressure points and ulcers. Actually, rock bottom. It's staged. Simply put, I like to think of it just hot, cooling, and cold. But the stage 0, obviously, it's hot but not changing shape. 1, it's hot and it's changing shape. Cooling is when it starts to heal. So that's the healing phase. So they call that the inflammation stage, the healing phase, and then the healed phase. So these stages of Charcot, if you want to learn that. I've put stable or unstable. You'll often read in the literature, it claims that after they've gone through the cold stage, that they become stable and solid. And that's obviously the best time to operate on people if you've got a choice, because the bones are strong. But the reality is they're often unstable. They flop around even after they've healed. So just be mindful of that when you think about how to treat them. Because doing simple little things on a floppy foot probably won't work. You're going to have to think about something more structural. So what else could it be? Really important, you don't just look at a hot red foot in diabetes and go, oh, it's a Charcot. So anybody know who that's supposed to look like? Elvis is supposed to look exactly the same as Donald Trump, and that's what he put on his own thing. So just be careful about, people thinking they know what they're talking about. One is infection. That's the easy one to do. High CRPs, biopsy if you have to. That's the word I want you to take away today, biopsy if you have to. Don't be afraid to biopsy these people if you're not sure. Obviously trauma, we talked about sensories and the fact you can get inverted trauma. Inflammatory arthritis has caught me out before. I thought it was a Charcot and it turned out to be a gout. So just be careful. You can see those going through the system. And put old Charcot, so it's quite typical. Charcot only happens once in your life. You don't really keep getting it. It's like a once and then it goes cold and it seems to stop. But you can get patients coming back with the foot goes hot and red again, and it's probably just good old-fashioned arthritis from the misshapen bones. And that they've overdone it, the foot goes hot and swollen, they get temperature tested, you rest them for a week, you take them out the boot, you find the temperatures are normal again. So that's just a tip there for that one. Obviously, if the other foot is cold, it'll also, oh God, I wish I hadn't done that now. If the other foot's cold, you'll get a different temperature difference as well between feet. Ulcerations. The way you look at an ulceration of a foot is, I think it's quite important to understand that there's definitely a grading system called Wagner's. Do you have to know that for exam? Probably not, but it is quite a useful way of just thinking about foot ulcers in general. And this is really going down the line of just how bad is it? Is it superficial, deep, forming abscesses, or heading towards the gangrene, which is obviously the necrotic tissues versions. And that's the way to look at it. How do I like it? It was interesting you said don't bother with the smell. I always smell these feet. Yeah, I'm not kind of going like them. But, if I walk in the room and it stinks, I'm kind of going, yeah, we've clearly got a pseudomonas problem. We've clearly got an anaerobe problem in here. And it really helps me go beyond it just a stinky foot. Where is it? It's really important to do that. And I'll show you a slide in a minute about why that's so important. How big is it? Is it 1 centimetre, 10 centimetres, whatever else? That's not in the grading, but very useful to know. How deep is it? We actually do measure it with probes. So we'll put a probe into it, pulling it out and say it's 4 millimetres, 5 millimetres, 10 millimetres. It's quite a nice way of you seeing if it's healing up as well, if you want to treat it conservatively. And does it go anywhere? That's the obvious one. Endpoint to bone equals osteomyelitis, just for your benefit. So if you feel it and it goes crunch, it's osteomyelitis until proven otherwise. And that's about 98%. And obviously the sloughs and the pusses will help you out. And I don't forget to mention the skin changes. You talked a little bit earlier about some of the problems you have with VAX, I think it was, the macerated skin. I'm not so worried about the macerated skin. If anything, they need a bit of moisture in their skin, these people. It's more, is there the cellulitis? Is there the obvious tracking problems under the skin? Is it gone dead and necrotic? Because they're not ones to watch. You have to get in there early for those ones. So I mentioned where it happens in your foot matters. And I'm curious, does anybody sort of know what percentages that you'd have? Say, we'll go simple, forefoot, midfoot, hindfoot. How many of these diabetic foot ulcers do I see that are going to be in the forefoot area? Anyone want to hazard a guess, a random number? How many? About a third? No, it's about 90% of them are all going to be forefoot. So that goes toes and that area. What about the midfoot? It's about 5%, very rare, usually only with the Charcots. Yeah. And what about the heel one? It's about 5% again, because you know your numbers. Well done, you. But these are nearly always related to something that you've done wrong in your Achilles. So either ruptured, lengthening, something like that, so the overload on the heel. The reason that's important to know is that, frustratingly for us, 1% of those end up with a BKA, 30% of those end up with a BKA, and over 50% of those end up with a BKA. And I don't know a foot surgeon in the country that likes dealing with heel calcaneal ulcers. They're a pain, they're difficult to do. And all of you out there that want to get into diabetic feet, you'll probably lengthen an Achilles some point in your life and think it was a good idea. And then a year later, they'll come back with an ulcer under the heel and you wish you hadn't, because you've cured that problem, but made a new problem there. So just to be quite mindful of that one. So I don't know how far into my 15 minutes I'm supposed to be doing. Am I? Yeah, I thought I would be. I told him to tell me. So anyway, that's the end. Any questions?
So just, I need to just clarify the thing which you said about the biopsy and infection.
Yes.
Because we have changed in a way where biopsies, we don't do biopsies anymore. How does it help you?
So when you're in the scenario of going, I don't know why this foot is fat and red and horrible, an MRI is not going to help you. A CRP is probably not going to help you. A white cell scan is probably not going to help you. You have all these hundreds of tests and you're sitting there saying, do I just put my antibiotics and just assume? Do I go in and just do a big full open debridement and remove on the assumptions? And we don't. We go in and we biopsy.
But the biopsy doesn't help you either, because if one positive, negative doesn't help you in the overall. Because if it's positive, you can't confirm it's infection. It's negative, you can't confirm there's no infection.
But we do the 5 samples like
no, if you do 5 properly.
No, this is intraoperative.
Oh, it is intraoperative.
Oh, yeah. Apologies. No, I'd take them into theatre.
I thought when you say biopsy means prior to surgery.
Apologies. No, I take them into theatre and I do it properly. And as I was explaining to someone in my group earlier, it's a weird thing to do because they're numb. And you're thinking, I've just GA'd you to stop you going through pain, but you're numb. It's a bit of a weird one, but anyway.
Can I say something? Different departments have different policy. Kings would do biopsy in the clinic. They claim they get a positive response with it. They claim. I don't do that because I don't think that helpful. Intraoperative, as James said, that's what I believe in.
Yeah. If I'm going for septic arthritis or something, that's different. I'd probably go for an aspiration or something. But if I'm going for a bone, it's 5 samples.
And I think the only thing, just another comment on that, so ones that do it in clinic, so you don't want to be biopsying through your ulcer tract. So presumably they're still biopsying through good skin, even if they're doing it in clinic, are they, in King's?
I mean, in my practice, how often am I doing that? It's very, very rare.
Yeah.
Because nearly everybody that's got osteomyelitis has got an ulcer. And you're not biopsying them, you know they're infected. So you just go in and do all the stuff that Prof taught me and go down that route. It's just the closed ones. Every now and again you get a closed one, you go, this could be infected, I better go down that route.
Yeah.
Just a question about the reports we get on X-ray about periosteal reaction under the ulcer, and the questions that come around whether is this just a reaction that's happening because of the overlying ulcer, whether it's an infection. How do you usually take it from there? Do you request an MRI for all of them, or do you go more with clinical?
Yeah, it's a really good question. And your problem with the periosteal reaction is it's not just infections that cause it. So it could be post-traumatic, could be overloaded, could be a few other reasons. So I don't necessarily use periosteal reaction on its own as a sign of infection. You might look at a serial number of them and make some decisions that way. The MRI scans I do very rarely. I do an MRI scan if they've got an infection. I'm looking for where's that pus tracking to. Because occasionally you'll have like a midfoot one or even a forefoot ulcer, and it's going all the way at the peronei into the calf. And I'm trying to get that with the MRI scans. That's what I do. What we were looking at with the MRI scans when we went in our practice is that we had a hell of a lot of false positives. Is that they all look like they were in osteomyelitis, and then when we go in there, a lot of our biopsies may come back negative, and we'll put patients in unnecessary procedures. So I try to avoid MRI just to not have that report that says it's osteomyelitis, and it's not.
So the other thing about it, if there's a foot which is hot and swollen and closed, no wound, it is Charcot. If it is open and there's a wound, then there's a likely infection, not necessarily, but it's closed. It's highly unlikely. Highly unlikely.
Yeah.
I've seen lots of things opened up and washed out, but that's there's generally Charcot. They don't do very well.
I 100% agree with that until you get the one with the CRP of 200 and has that picture and they've got a chest infection and you go, I think it's the chest, but it might be the foot. Because they do get septic arthritis, these people, like anyone else. You know, they do get gout like anyone else. They do get all these other things that happen to them.
Thank you.